The atrioventricular septal defects. These are also called as AV canal defects or AV septal defects, and they are a spectrum of disorders or anomalies with pathologies ranging from resembling a simple ASD to a single ventricle. So there is a wide variation between different types of defects that we can. After the primitive tube formation and looping and septation of the heart and development of the AV canal occurs, and you can see the septum primum formation in the cross section. Endocardial cushion tissue is at the heart core and grows towards the posterior wall of the common atrium, forming the atrial part of the AV septum. And this is not the septum primum, and this tissue forms the bottom of the fossa ovalis. The endocardial cushion's contribution to the atrial septum fails a primum ASD result, which is a deficiency of the septum secundum. As endocardial cushion tissue grows in the direction of the apex, the ventricular part of the AV septum, the muscular tissue just under the septal leaflet of the tricuspid valve, is formed. And this is the procedure in a faulty manner, and inlet VSD result, typically a pressure restrictive diminutive VSD. If there is also a defect in the inlet septum formation, a large unrestricted VSD is produced. The septal leaflet of the tricuspid valve and the anterior leaflet of the mitral valve are created as the endocardial cushion tissue grows rightward and leftward. The failure causes the mitral valve and tricuspid valve not to form by the definition, and the atrioventricular canal defect of any degree forms superior and inferior bridging leaflets as well as the lateral leaflets, which forms the components of the left and right atrioventricular valves. This is why when we refer the patient for the defects, the right and left AV valves have a complete annuli and no ventricular defect. They should not be referred to as a tricuspid or mitral valve, since they do not have the same anatomy as those of the valves. So something about the endocardial cushion. The atrioventricular canal divides between the atria and ventricles and the endocardial cushions. There are 4 tissue expansions found in the periphery of the AV canal and cause the atrial septation, atrioventricular valve formation, mitral and tricuspid valves, and ventricular septation. The superior inferior cushion has septum intermedium, inferior atrial septum, and posterior superior ventricular septum. The right and left cushion, the ventricular myocardium, mitral valve, and tricuspid valve. And this is a diagram showing the atrioventricular valve formation. There are different types of defect which we are going to discuss. A partial canal defect is a primum ASD, typically with a complete anterior cleft of the atrioventricular valve, although it may be incomplete. A solitary anterior cleft without the ASD is not considered as a canal defect. There may be a gooseneck deformity of the alveoli, which is elongated, and the elongation of the alveoli is due to apical displacement of the atrioventricular plane. And this displacement occurs because there is at least some deficit in the ventricular part of the AV septum. The elongation does not automatically result in alveoli obstruction, but the caudal attachment or accessory tissues in this region may present that cause the alveoli obstruction sometime. Then second is the transitional AV canal, which is a partial AV canal with a pressure restrictive VSD and it may also be associated with LVOT obstruction due to caudal attachment from the anterior leaflet of the mitral valve to the septum. The complete AV canal defect cause a primum ASD, an unrestricted inlet VSD, and a common atrioventricular valve. There are three types of common AV canal defect, which is classified according to Rastelli classification. For Rastelli A, B, and C. For Rastelli A is common and defined by the superior bridging of the leaflet having the cords attached to the right and left sided components to the appropriate side of the septum. Rastelli B, it's rare and almost never seen with balanced ventricle. Straddling cords extend from the right AV valve component into the LV, usually in cases of LV dominance, or from the left AV valve component into the RV, usually in cases of RV dominance. Rastelli C is defined by the superior bridging leaflet, usually without any caudal attachment to the crest of the ventricular septum, and this is the type the most often associated with tetralogy of Fallot and double outlet ventricle. The unbalanced AV canal defect, in which a common AV valve lies predominantly on one side or the other side, is seen in 10 to 25% of the patient. This leads to hypoplastic ventricle on one side and with a smaller AV valve orifice. In the AV canal defects, both the coronary sinuses and the AV nodes are displaced inferiorly, and the bundle of His travels in the inferior leftward aspect of the crest and the intraventricular septum from approximately 50% of the crest length. The associated cardiac anomalies may include tetralogy of Fallot 10%, PDA 10%, LVOT obstruction, multiple VSDs, double orifice mitral valve, single papillary muscles, and double outlet right ventricle. Transposition of the great vessels and truncus arteriosus are rare anomaly, and the most important associated non-cardiac anomaly is Down syndrome. Approximately 50% of the children with Down syndrome have the canal defects, and 75% of the children with canal defects have Down syndrome. Interestingly, it is rare for the partial AV canal to be associated with Down syndrome. Also, patients with Down syndrome are frequently not associated with LVOT obstruction. So this is a 4-chamber ultrasound view of 24-week patient, which shows all the 4 chambers, and a congenital heart defect with endocardial cushion can be seen. There is common atrioventricular valve. So in these patients, there is left to right shunting with resultant increased pulmonary blood flow, which is usually associated with the size of VSD and a degree of atrioventricular canal. Therefore, the medical therapy consists of anticongestive measures and afterload reduction if AV insufficiency is significant. The complete defect have large left to right shunt with elevated RV and PA pressures owing to the unrestricted VSD, and they present early in 4 to 5 weeks with symptoms of CHF, feeding difficulty, tachypnea, and failure to thrive. CHF symptoms are more pronounced at presentation in earlier and significant left AV insufficiency. The LV underdevelopment of the left-sided obstruction, LVOT, and aortic coarctation and hypoplastic aortic arch, etc. are present. These lesions will result in development of pulmonary vascular occlusive disease if not repaired in infancy. When there is little or no AV insufficiency, AV valve insufficiency, partial or transitional canal defect present later and can have a similar presentation and a natural history to the simple ASD. It is important to note that the patient with Down syndrome have reduced peripheral bronchial vasculature increased secretion, bronchial plugging, and tendency towards hyperventilation due to floppy airways. And thus, in these children, there is pronounced tendency towards the accelerated pulmonary vascular disease, and the pulmonary hypertension is present, which is why repair is usually recommended prior to 6 months of life. Diagnosis is often made by parental and fetal ultrasound and subsequent fetal echocardiography. In infant, chest X-ray shows increased pulmonary blood flow, increased pulmonary markings, and reveal the dilation of the cardiac chamber and left atrial dilation. And ECG may shows counterclockwise left axis shift to the inferior displacement of the bundle His. The echocardiography is diagnostic and most important intraoperative and postoperative assessment of the AV canal competence after repair. The altered loading conditions in the postoperative period can manifest acute MR days to weeks after repair, and the cardiac catheterization is rarely done in isolated AVC patient except those presenting with late 9 months of age with a complete AVC signs of significant pulmonary vascular disease. A small heart, cyanosis, and good weight gain catheterization may show gooseneck deformity. So the timing of the repair is based around preventing the obstructive pulmonary vascular disease and chamber dilation, which can be caused by additional pathological changes of the AV tissues. However, as a young age, in less than 3 months, the surgery is more difficult due to fragility of the tissue, and beyond 6 months of age, the risk of obstructive pulmonary vascular disease as well as need for reoperation increases significantly. Thus, while the optimal time of repair remains controversial, the most agreed and complete repair is ideal between 3 to 6 months of the life. For symptomatic patients who are less than 2 months old, the PA banding is commonly used for palliation. The timing of the transitional canal differs depending on the size of the ventricular component, which often decreases in size over time. Patients with a partial or transitional AV canal defects are usually referred as surgery dependent, and symptoms or if developing significant AV insufficiency, with a vast majority of the asymptomatic patient sent for surgery between 1 and 3 years of age. So the partial AV canal repair consists of the pericardial patch closure of the primum ASD. A patch is sewn into the region of continuity between the right and left AV canal closure and the primary component of this repair. When closing the primum defect, one can choose to run the patch inferiorly around the coronary sinus in order to avoid the conduction system. This will result in a small right shunt. However, there is well tolerated and a common surgical strategy. If one runs the patch in front of the coronary sinus, the bites from the inferior ventricular septum to the annular intercept to pass the coronary sinus must be quite shallow to avoid the conduction system. Repair of the transitional canal is similar regarding to the primum defect. The VSD of this type of canal defect is most commonly located at the level of the MV cleft, and a single horizontal plageted mattress suture placed at this location obliterates during the cleft closure. This stitch usually passes through the ASD patch, and if there is other cleft, there is usually also closed, placing the sutures on the right side of the septum through the leaflet and then the ASD patch. The complete canal defects can be repaired using either a one patch or two patch technique. Additionally, the left AV canal should be closed, as that has been shown to increase the survival and decrease the need for reoperation of the AV canal. And the exception would be in patients where the closure will cause the stenosis, for which the partial or no cleft closure may be best. In the two patch technique, the separate patches are used to close VSD and ASD. One patch repair can be performed in the modified Australian manner, and the traditional one patch repair involves the incising superior and inferior bridging leaflet and reattaching them to the autologous pericardial patch, and after securing it into the ventricular crest. In this repair, the multiple interrupted sutures are placed on the right side of the crest and the interventricular septum to avoid the bundle of his and branches. The sutures are then passed through the superior inferior bridging leaflets and then thought to be autologous pericardial patch, which is used to close the primum ASD. Prying these suture closes the VSD by bridging the common AV leaflets down to the crest of the septum. Some believe that the VSD is large and the technique can amplify the gooseneck deformity and cause the alveolar obstruction. So some surgeons seem that this repair may not improve the outcomes which advocate two-patch repairs of the patient with large VSD to prevent alveolar obstruction. Although biventricular repair is preferred and often achievable, a single ventricle palliation may be necessary in some patients. The concomitant lesion and the risk factors associated with the need for single ventricle palliation include unbalanced defect, particularly the LV hypoplasia and double outlet right ventricle. Patients with unbalanced defects, especially in those of the patient with trisomy 21, may be the candidates for biventricular conversion from single ventricle palliation with relatively low mortality. The perioperative mortality is around 2% and incidence of the heart block requiring the pacemaker is 1 to 5%. Mortality significantly increases if associated with tetralogy of Fallot. Double outlet right ventricle is 7% to 6% respectively. Early mortality even higher in the patient requiring the single ventricular palliation at 11%. The most common reason for reoperation of the left AV valve regurgitation is 5%. Risk factors for reoperation on the left AV valve have varied depending on the studies but include significant postoperative, preoperative, and left AV valve regurgitation. Younger age, trisomy 21, partial transitional canal, and open cleft, and some studies have shown that the Down syndrome patient experience better outcome, including less reoperation on the left AV valve. Down syndrome patients often have the increased tissue that may aid the more durable repair. However, these patients may experience most perioperative complications. The pulmonary hypertensive crisis can occur in some cases of the late repair, but it is not common. Patients with a small heart on the chest X-ray or bidirectional shunting on the echo would increase your suspicion significantly. Despite this, the catheterization is usually not obtained since one would attempt closure and to treat the pulmonary vascular disease unless it is very extremely rare. In these patients, nitrous oxide or inhaled prostacyclin may be important for management. Thank you. Hope you have enjoyed this presentation. If you have any comments, then please feel free to write in the comments. Thank you.